Indeed, a great pleasure to welcome Aneesh. Aneesh is well known to many and to most of you with his, first having being our first U.S. Chief Technology Officer back in 2009 through 2012, and the fourth Virginia Secretary of Technology. With that, I'm going to turn it over to Aneesh because I know that time is quite dear today. So Aneesh, thank you again for joining us.
Thank you so much for having me. I don't know where you found that action shot, but thank you for, I'm very serious in my photo here. Let me see if I can, we're a casual group today, and I think we're gonna have a conversation, which may be the most productive thing we can do. I think what I need to do is ask if I can control, let me see if this works. Let me know, Charles, can you see my slides?
Absolutely.
Great. So look, I did prepare materials per the discussion that we had, but I want to start with more of a fundamental point of view. And it was the conversation you and I had, and I want to sort of tee it up to this group. And I've titled the presentation, "It's on Us. How to Accelerate Delivery Reform on Regulated Data Sharing Standards." And I say that because as many of you on this journey with WEDI know, the US is unique in that we have a very strong private sector-led standardization process, and we fall short when we can't self-organize to make a difference. And I think it would be charitable to say we haven't made as much progress as we like. And I think the more candid answer is, from my perch as CTO, the healthcare industry ranked dead last in its willingness to collaborate on technical consensus standards. And it's super frustrating. I don't understand it. It doesn't make any real common sense. And while there's lots of goodwill, there's just way too much friction in the system. As a point of comparison, usually it's the evil banks that are seen as sort of like, highly competitive and, lots of money at stake and huge part of the American economy, global economy. I remember vividly, as we were going through the reform agenda, we regulated the banks in Dodd-Frank to provide consumer application access to their checking data. And around the same time, we were talking about Blue Button and about consumer application access to their health information. And Congress gave the Consumer Financial Protection Bureau the legal authority to regulate the banks and to force this capability. And as you know, well, we now know as the Cures Act, even before the Cures Act, I would argue, Congress voted not once, not twice, but several times from the Affordable Care Act, from the high-tech provisions of the Recovery Act to MACRA, and then of course to the Cures Act. Congress is screaming at the top of its lungs, we want this to happen in healthcare. Now, what happened? If we had a virtual seminar, I'd ask you to raise your hand, but I'd be curious to get anyone's take on, when the Consumer Protection Bureau issued a regulation to require application access to checking account data. And I'll proverbially pause, but the answer is it never did. The Protection Bureau never even had to propose a rule. The industry self-organized. They adopted a similar to FHIR, an OAuth-based standard. So now people can go on mint.com and they can now officially connect using sort of technical standards with all that they can do in the same way we needed to make the healthcare system work. So we've had countless regulations on the healthcare side, and we're still frustrated that we haven't gotten where we want to go. And no regulations on the banking side, and they've done it. In Europe, they've gone a step further. They have a read-write technical standard. You could actually write back to the financial ledger and you can facilitate transactions like payments. So they've gone a step forward, and the global banking industry has adopted it. Okay, so that's my wearing my former policymaker hat, expressing the frustration about our inability to get it done. And of course, we'll have it's incentive, it's this. We could spend the full hour on just all the woe is me, why we can't do it. The reason we were eager, I was talking to Charles about today's discussion, is the most recent attempt by CMS to introduce technical standards for purposes of lowering, in this case, physician burden, met with massively uniform opposition. I was telling Charles, I think the Weedy letter might be the only letter that CMS got that was like, oh, yay, let's give it a go. And I don't even think you wrote that in your letter. I wouldn't call it give it a go. I think you're like, hey, we like the spirit, blah, 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 whatever. So the point is, here you have like a huge problem. And, the industry basically hadn't organized itself to test and implement an approach. And so we don't have a standard that's mature enough for the regulators to regulate. And when they try, they get huge pushback to say, oh, the standards aren't ready. You can't force us. And it's super frustrating. So if there's nothing else to take from today's discussion, it is my hope that there'll be a safe place, and maybe it's weedy, maybe it's not weedy, but someone has to put the parties together who are willing to actually test and validate that these capabilities can be standardized using modern infrastructure. And then I guarantee you the policymakers will find a way to scale it through regulation. So given that, let's now see if we can get moving. I'm going to walk you through a little bit of the argument about the big picture. Obviously, the Biden administration's prime objective is to build back better. I had the honor and privilege of serving on the transition team, although in an odd capacity. I worked on the U.S. Postal Service. I've learned a lot about the Postal Service. If any of you are curious, I'm happy to have a conversation about it. But here's what I want to suggest to you as it relates to sort of information technology on Build Back Better. Look at all of the creativity that's been brought forward on COVID. Obviously, this has been a terrible tragedy for the country, but look at what we're able to do in a very short period of time to take really a massively opaque delivery system, i.e. real-time bed availability. I mean, could you imagine if we had a conversation, hey, I wonder if we can get real-time bed availability in, for every hospital in America to be able to look at, capacity for public health, in order to issue these public health orders. I would have said, no way, you can't, that's a hugely complicated thing. There's no transparency on this stuff. And here we are, a year later, every hospital in America submits this sort of weekly data, or I should say daily information. And then there's a public use file that every one of us can access and use to get kind of a heat map of the current healthcare utilization in this country. If you said to me, we would get this in less than a year, I'd have said you're smoking crack, impossible. And yet here we are. Then we went into this whole issue about how do you report lab results? For those of you who remember, we started the pandemic with lab results basically incomplete. We had race and ethnicity were missing, and forget about any other clinical context. When the first CDC paper was published on the 4,000 patients that had COVID, and they had to report 92% of those individuals lacked any clinical context in their case report file. That is to say, our country's public health infrastructure had nothing more than basic ELR data to decide what this disease is, how it propagates, who's affected, etc. I mean, so frustrating. So now we're at a place where I'm a volunteer in the Chicago Data Hub. You've got pockets around the country where public health officials can integrate EHR records and ELR feeds and even ADT feeds to track disease progression over time. And people are synthesizing that information for public health. This slide says it best. The administration, the Trump administration, building upon the Obama administration's work on the US digital service, dispatched the largest digital services team it had fielded for the CDC Prime Initiative, which, if you see the links on the left, are examples of what this sort of stealthy, startup-y culture can produce. Now, hundreds of schools, assisted living facilities, and others that had no EHR, no technical capacity, are now using really thin, simple, lightweight, internet-based technology called simplereport.gov to aggregate all of the individuals in the community and then track, if they get routine testing, to see anything that comes in for purposes of reporting to the government what's cooking. At the bottom of the page, you'll see a blue box called Report Stream. This is now a universal catcher's mitt, interface engine or integration layer that is able to ingest that simple report feed or ELR feeds and hospital feeds, including, we're building towards CCDs and other content, organize all that information, and then make it resulting information available for state and local government. We are building public health infrastructure, building back better. For the overall system, however, we've got a long ways to go. And I'm going to go back and forth between interoperability regulations, value-based care, and sort of how all these pieces may come together around consumerism as we kind of finish the discussion. And Charles, I'm wondering, we've got the hand waving feature. We got to figure out what Zoom etiquette for today, but if people can raise hands or post a note in the chat, I don't want to be blathering on. If there's questions or a way to gather that feedback, we can pause and talk, whatever you think is appropriate. It's a small group, so I don't know if we can unmute everybody or whatever you want.
We're going to try with, we've asked people to put their comments in the chat function. We'll try that, and otherwise maybe Samantha can open it up for questions in a different manner. So
Whatever
we'll try.
works. Yeah. Yep. All good. So this is sort of a dense slide, but here's what it basically says. The poorer you are, the more we screw you in the delivery system. That's not news to anybody on the line, but with the Biden administration's focus on equity, I think we're going to have a lot of interest in figuring out a way to fix this. So just a quick run around the table here. The Trump administration included, as part of the tax reform bill, a program called Opportunity Zones. And these were neighborhoods that were measured by their level of economic distress. And so the foundation of that was something called the Distressed Community Index. And so if you look at the far right, the 5,000 zip codes in America that are the most economically distressed, the average Medicare patient in those communities costs more, has a higher HCC score, and has a much lower likelihood to get preventive services like flu shots and wellness visits. Now, the tool to solve for this lack of care coordination had been the Medicare ACO program. We thought we could put more people into value-based care. And as you can see on the bottom, the penetration rate of ACOs in those economically distressed communities goes down. It turns out not as many stable PCP relationships and or PCPs willing to sign up voluntarily to the model. And look at some of this depressing stuff. The most economically distressed ACOs actually had better results on annual wellness visits than the richest zip codes not in an ACO. We clearly need ACOs to boost, at a minimum, physicians spending the 30, 45 minutes necessary to understand your needs, build a care plan, and hopefully work to make sure you're adhering to that plan. The most recent fascination for me has been, I'm a big believer in the price transparency rule. It's going to be a bit of I think the surprise billing legislation at the end of the year is going to be my favorite, because it's going to make every health plan in the country scramble to get all this information up to date. And I got to believe that they're going to have to put this through APIs. because there's going to have to be either that or there's going to be one big vendor gold rush to be the one platform to rule them all on facilitating access to pricing data. This has to be API. I don't know how it else. I just don't know how else we're going to do it. So we have now a huge kind of legislative vehicle by January of 22 to get all of this information into a computable format, which is great. The Wall Street Journal article this week really did blow my mind. Hospitals had to go out of, first of all, if you ask me how many hospitals knew that you could block a search engine from going on your website by writing in the words norobots.txt, I would have laughed. 0% of hospitals in America had any web page that had a norobots.txt on their page. I mean, what is that? How ridiculous. And yet they figured it out to block access to their price transparency information. I mean, how pathetic, honestly. I'm so glad the Wall Street Journal ran that article because it scared everybody. And you could see how everybody's like, oh, IT made a mistake or whatever. No, they didn't. That is obnoxious, right? Absolutely pathetic. So I'm glad. And you could see an example of what, kind of a machine readable price transparency table looks like on the web. We're going to see a great deal of time and attention focused on payer and provider transparency. The payer side goes live next January. The provider side is already live. Of course, we'll see if people just pay the penalty and not do it. But anyway, very exciting. So, which leads me to the final of sort of the national policy questions issue, which is, look, the Medicare Trust Fund is in fact struggling. We know that we're hitting the proverbial limit in terms of when we go into the red. And so we've got to figure out a way to fix this either through value-based care, or we'll find ourselves on the other end of another big rates reduction, slash the rates situation, which feels like it's not going to be good for anybody. Well, the value-based care story is not perfect. If you look at the white paper or the blog post or the article that Brad Smith, the former CMMI director, published at the end of the year, of all the Medicare tests for paying doctors differently for value-based care, the overwhelming share of those models lost money for the taxpayer. Now, people may disagree about the methods that Brad used to write this article, and maybe another actuary could take a look at it and say, no, we actually made money. Regardless, it hasn't been the home run. I'm grateful that the Medicare Shared Savings Program shows promise, and it's the little engine that could, but it doesn't have the kind of universal impact we wished it would a decade later. This point about we need models that are going to make a difference is a big reason why you're seeing so much political attention on something called the direct contracting model. It is the latest attempt by CMS incorporating all the lessons learned from MA, which also overpays fee-for-service, and all these models that didn't quite work to build in some balance on day one. CMS is going to take savings off the top and still create an economic model that will reward practices for being, for organizing care for those folks. Denny, I appreciate your commentary. I won't make comments about MA in the same way you do, but the point being, if the goal is to save the Medicare Trust Fund, that is not the way to do it. Certainly, it does other things. It gives people benefits. It provides coordinated care, and I'm all for those things. But it is not a trust fund saving platform. So the point is, a lot of attention is geared towards the direct contracting. If there was an ask of the weedy community, it is to design administrative simplification strategies, payer-provider collaboration strategies on the shoulders of the Medicare direct contracting model, because it will create the kind of integration framework we need to bring people around the table who want to get to yes on data sharing and application integration. So while a payer and a provider might battle like yesteryear on rates and so forth, They are absolutely committed to collaborating when it comes to the Medicare direct contracting. And because so many payers have agreed to be direct contracting entities, and we'll find out in the next few minutes, I'm 100% aligned that if we created a happy place, Charles, a happy place where we want to work together, not like tear each other apart, the direct contracting program gives us the technical happy place to work together. So let's spend a few slides on what that happy place looks like, and then we can have the remainder of our conversation be a bit of a debate and a dialogue. And then really what I'm hoping for is who's in. If it's on us, who's going to raise their hands to say, I want to help. I want to be a part of this. I'm going to volunteer my time. I hope many of you will. We need a place to get good energy together. Adele, thank you for noting the payment models work group. I'm not familiar with that, but it sounds awesome. And if you could help, God bless you. So let's go through kind of a few key pieces and parts to the how direct contracting as the happy place can be a mechanism for collaboration. So let's start with how the consumer blue button API obligations fit within the direct contracting model. Thankfully, the model involves 3 capabilities that involve consumers, all of whom have clear ROI for the industry. Number 1, when you enroll in a direct contracting entity, that entity would be very interested in having access to your claims history. By the way, sounds very much like payer-to-payer exchange. That's in the interoperability rule. But before we get there, let's start with the first principle. I'm brand new to a direct contracting entity. I want to, and you recruit that consumer to join your direct contracting entity. I want to bring your claims history so that I can get to work on day 1. As everyone in this call knows, CMS has been live with their blue button API since 2018. If you take a look at the named entities that are on the 60 plus apps approved for CMS, you might note that many of them are payer sponsored apps. So in a way, we have payer-to-payer exchange already live, and it's driven by consumer opt-in, and it works. Now, in that case, it's really around fee-for-service switchers to MA, and it's often the insurance tech divisions of the plans, but great. If that's where the economic value is for the plans and they want to put tools into consumers' hands, God bless America. So we envision a feature where individuals can share their blue button file. And I think that, so there's compliance with sharing blue buttons. That is to say, you've got to enable it. I think the direct contracting entities are going to be the yin to the yang. They're going to be the place that consumer designated apps tied to an accountable network are going to be, on the right side of the ethical line to organize that consumer mediated data for good. Perhaps most interesting is the middle bucket. And this is a screenshot, again, in disclosure, Care Journey works with companies like Trusty.care, which is a blue button app. We work with Village MD and so forth and so on. So just to acknowledge those disclosures, when you see screenshots, it tends to be organizations I'm working with. Village MD is live on their direct contracting entity. And I've given you a screenshot from one of their web pages where CMS has created a very interesting program called Voluntary Alignment. Instead of leaving Medicare fee-for-service to go into Medicare Advantage through a sales process and a broker, you can actually stay in Medicare fee-for-service, but by confirming your PCP and if that PCP is participating in this direct contracting model, CMS will give that PCP your capitated premium. $10,000 to $12,000 PMPY. So imagine that. We're going to see clinical networks competing to convince consumers to join their network. That is really exciting. Hopefully, they're going to be focusing on those individuals that are falling through the cracks, given the equity agenda. Folks that live in underserved communities, don't have a stable PCP relationship. There'll be strange bedfellows involved. I've been praying and hoping that the Walmarts and the Walgreens and the CVSs of the world will leverage their retail footprint to kind of encourage folks to get more coordinated care. And wow, all of this is now possible with this opportunity. So that's the second piece. And then, of course, the third piece is that these direct contracting entities, they're actually administering new benefits for consumers. Maybe it's benefits like I'm going to give you a voucher to fresh food at the local supermarket, or maybe I'll pay you a gain sharing fee if you go to a high value doctor or a high value imaging center that is going to meet your clinical needs, but at lower cost and with better outcomes. All of these capabilities will be administered, hopefully, in a digital way. And I call that the era of consumer designated networks. So this is bringing the consumer blue button requirements to life. And by the way, I'm really curious how many plans may follow CMS's suit and allow for their members to opt in to the model. Adele, you're asking a great question. There are at least 50 direct contracting entities that were named in the first implementation period that went live in October of last year. We don't know how many will go live April 1st or whatever it is, April 5th or 6th, whatever that day is after Easter. So we're all guessing. Of course, we'll know when CMS publishes the list, but my guess is we'll have about 75 live in the initial batch. That may be a little bit high, maybe it's 60, but it should be a reasonable number. We're all focused on who's going to go live in 2022. And the reason for that is most of the providers that already operate ACOs couldn't be both enrolled in an ACO and a direct contracting. They had to decide which one. And since this first year was sort of delayed due to COVID for 3-4 months, they didn't want to be out of a model for a quarter. So they kept the ACO model for another year, and they're going to flip into the DCE model next year. Now, here's the more important point. If you are a payer and you're looking to build upon this program, this is the chance. By the way, Katrina, thank you for raising concerns. Your concerns are exactly why we want mayors and other stakeholders to actively participate in the marketplace. So the mayor of Houston is actively engaged in ensuring that his Complete Communities initiative meets people where they need to be and not about digital literacy. And by the way, I think that help sort of digital literacy issue. Now there's a business model for organizations to fund the communications into, Meals on Wheels could be part of your preferred provider network, and it should. And that's what direct contracting allows you to do, is expand the universe of partners that you want to work with to help people. Because remember, you're not taking away anybody's benefits. You're adding benefits while they keep the Medicare fee-for-service program. So, okay, here's the bigger, now we get to the big issue. That CMS proposed rule on physician burden, it was chock full of functional requirements, chock full. We want to name a FHIR-based standard for the blue button requirements for the patient access API, rather than what it currently is, which is a bit of a functional requirement with a hope that you'll pick the Karen Alliance IG. The second item is that it introduces the idea of a physician access model. So patients for sure should be able to get their data, but why not reuse the same infrastructure for provider access? And CMS is live on it, so the technology works, but the issue is whether the industry could do it by 2023. By the way, I find it hilarious that CMS is in production with these very same industry standards, these bulk FHIR capabilities, and yet the industry said that it was not ready by 2023 to follow suit. I mean, come on. CMS didn't spend that much money on building these things out. I can't for the life of me understand how people can say they can't technically do it. It's ridiculous. Maybe they don't want to do it. That's a different issue. But there's no reason to say you can't technically do it. But here it was, give doctors the ability to access the same capability and allow them to use it at the point of care, preferably in their EHR, not logging into a separate portal. And of course, last but not least, there was an opportunity to run payer-specific applications. And maybe that was the big news around prior auth as a payer-specific application. So you have patient applications, provider applications, and then these payer-specific applications. And if you put all these pieces together, even if this rule doesn't go anywhere, those direct contracting entities have every incentive to still move forward on all three requirements. So what would MacGyver do if we didn't have a rule that forced us to do anything, but we had the opportunity to work on it? Well, number one, I want to thank Humana. I don't know if Humana is on the call today, Charles, but of course I work with Humana, so I'm also biased, but they were on the Care and Alliance webinar last week. They are live. Humana is live with their patient access API. Now, I think Aetna is live too, although they didn't demo, so I can't speak to that directly. But third-party app developers described their developer experience registering and engaging and using these technologies. And guess what, folks? They worked. What was interesting was Celie, the woman from Humana who presented at the Care and Alliance meeting, also noted that voluntarily they were testing whether a doctor that had a treatment relationship with the patient could access the same API. I'm not saying they're live or they're in production or anything of the sort, but the mere fact that they were willing to test it, 2023 is 2 years from now, folks. We could be doing the same thing. And they're building off of the same infrastructure. So I'm grateful that they've shown people that the water is warm on the other end of the pool. I'm also very active in the Argonaut project. And as many of you know, the Argonaut project has already finalized not one, but two specifications of bulk data or bulk fire with granular controls so that a provider or a payer could be really specific to say this physician can query this list of patients, no more, no less. Conversely, this payer can query for this physician panel's list of patients, no more, no less. So this concept of enabling that physician burden rule, I believe the pieces and parts are on the field for us to assemble that aren't new standards. We're not trying to race to create new standards. Use the standards that are already regulated and coming to market. In the case of bulk fire, ONC has mandated that bulk fire go live by December of 22. And my hope is that the payers choose bulk fire to comply with payer-to-payer exchange. That's a decision. I don't know if that's what's going to happen. I feel like it may be a bit of a kludge, but hopefully payers will choose bulk fire to do that. In 2021, for those of you who are curious, the Argonaut community, which again is Epic, Cerner, it's the major EHR vendors, are working on a few write use cases. So the patient can, the third-party apps can write back vitals, or for those of you doing things like HEDIS measurement and you're trying to get, for example, blood pressure readings from a home monitoring cuff back into the EHR, this is going to allow you to do that, which is very exciting, right out of the box. And then my personal favorite is subscriptions, which would allow you to establish the list of patients that you're interested in. And if they show up in the emergency room, you can subscribe to that feed, like an ADT feed. So ADT on Fire is now a reality, or it will be in this Argonaut project for 2021. And then for those of you who are interested in big data, probably the most controversial but exciting initiative planned for later this year is to standardize how an EHR vendor will respond technically to a patient's request to export electronic health information or the full record as defined by ONC and the information blocking rule. So we've got a lot of exciting things we can work on as an industry. But this in particular has me jazzed because it aligns with some of the key bottlenecks that we've seen. But it requires payers and providers to collaborate on how they can be used in the real world. Just because a EHR vendor agrees to a specification doesn't mean it actually improves patient care at any community facility in the country. So to kind of bring it home, I am working with a payer that's working with a provider to enable data sharing using nothing but the Argonaut ONC regulated FHIR standards. And we are demonstrating the viability of matching rosters, establishing a group ID token, enabling a query that can respond back with a bulk FHIR response so that a payer in this case can pull the necessary quality measures out of a provider's EHR, and that all of this is governed by contract. And typically these are in value-based care contracts. So Charles, I'll leave the last 15 minutes or so to a dialogue as to whether or not, those on this call are interested in collaborating, partnering, and whether you, Charles, want to offer a safe place for the community to do so that when and if CMS comes back with rules, we're ready with yes, not with woes of no. Thanks, Charles.
Aneesh, thank you very much. And boy, there was a lot that we just, you just went through. And I'm wondering if there are any questions and whether we want to, Samantha, is it possible to allow live questions, or we need to focus strictly through the app, through the chat function?
Sure, we can unmute folks. We, since we have a smaller group today, if anybody would like to speak up, you are all able to unmute yourselves. I will share some of the fantastic comments that were in the chat function. Still concerned about consumers with lower health tech literacy benefiting from these programs. And also, the healthcare industry is still primarily married to waterfall methods and long-term planning of all changes. And I think the culture is playing a big role.
Yeah, thankfully, compliance is going to force that culture to change. I'd appreciate, Adele, if you want to say a word or two about the sort of the role you're playing on this working group, and maybe if any of these items are on the list, if you'd be so kind to share. I don't know if we've met before, but nice to say hello. No pressure.
Adele.
You don't have, oh, there you are. Yep.
There
Adele?
I am. Okay. Yeah, so we have a work group, the payment models work group, and I'm familiar with the direct contracting model. I know it's just kind of getting its inaugural launch, and we'll be very interested to see what that data brings out. I love your take on this. The three models. I was taking copious notes about the three things that you laid out. The work group itself could actually use, we have a lot of people that come to the work group just for general education. I also believe that in the industry, there is a lack of knowledge of just some of the basics of value-based payment. So, I think there absolutely is an opportunity, particularly around the direct contracting model, to really do some education with the WEDI members. I don't know if that's what you were looking for.
Yeah, no, I appreciate that. We could also cold call on Amol. Amol, you got to say something about it. Amol is my man who put a lot of toil, sweat, blood, sweat, and tears into the development of the Karen IG. And I'd be very keen, Amol, if you have anything to say or comment or challenge the group on, but you're like the spiritual persona in my mind of someone that wants to kind of step up on the plate and make a difference. So maybe you could share a bit about how much time you spent on the Karen IG and the fact that your boss let you do it, And that may be sort of a case study for folks on the call to learn about. No pressure, Amol. If I see your unmute click, I'll call on you that way. Danny, tell us more about the Mass Health Data Consortium as we wait for Amol.
Thank you, Aneesh. We're small, and I think collaborating with WEDI makes a lot of sense with respect to understanding the evolution of the direct contracting model, understanding how what we do at a state level or regional level can be expanded or used to inform other collaboratives who are engaged in a similar effort. But we have in Massachusetts, a state where the preponderance of health plans are state-based health plans. And we have almost all of the state-based health plans enroll or participating in our data governance collaborative. We have about a half dozen health systems and physician groups currently involved. COVID has slowed or limited provider engagement, but that is picking up a bit as we speak. And what we're doing is we're going through a number of activities, tasks that have to do with, as my colleague Janice Karen mentioned, getting health plans to move to an agile approach to technology development because they don't have time to do things the way they've done them. Two, to establish not only a standard data specification, but more data specification that allows organizations who currently exchange data in a very limited and highly discrepant way to move toward the US CDI and to move toward FHIR-based exchange. So, we're trying to guide a group of organizations through what has been essentially a spreadsheet and, database tables exchanged in very differing and discrepant forms between the plans and the providers for risk adjustment, for HEDIS scores, et cetera, et cetera. And we've really taken the rules around interoperability, information blocking, and even the prior authorization ones to the point where we are also standing up an electronic prior authorization prototype built on the Da Vinci implementation guides associated with that. And we are just about to announce the payer and the provider who will be joining us in that. So we would love to work. We would love to work with you guys.
Yeah, can you just pause right there? So that is probably the most important thing you've just said. So if you have a payer and a provider willing to work together, so here's where I'd like to ask your permission to think about verbs, not nouns. The verb is, what is the functional requirement you want to accomplish? And then the series of nouns, in my opinion, would start MacGyver style. What do they have today out of the box? Not custom interface, not custom programming. And the reason I say that is, in order for those projects to scale, they need to be sitting on top of a regulation. And unfortunately, with that rule, had that rule gone final, you would have been in a great position to be an early adopter of a new rule that was due in 2023. I'm not convinced that that new rule will come back in its form by 2023. That's a judgment, right? And so we either hope for the future rule that may come out that does this, or you take the payer and the provider and you get them to work together on what is regulated, which is the ONC bulk FHIR specification and the Karen IG patient access API for July. And hopefully the bulk FHIR specification for payer to payer in next January. And I don't know if you've got capability to think about what you're testing, but if we could get to CMS, here's how your functional requirements can be met on the regulations that exist today. And here's all the tweaks that need to be made to fix it. I gotta believe CMS is going to be very excited about that in whatever future round of the rules they may come. Is that, and I don't know if that, I'm going to put a link in the chat, Denny. In
Okay.
2019, at the White House Blue Button Developer Conference, and if I'm going to just quickly put this in the chat, let me just see if anyone can remember this. Charles, if you remember this, this is ONC and HL7 publicly announced a steering committee of early adopters, payers and providers who were willing to voluntarily adopt and use the bulk fire standards before they were regulated. Now, unfortunately, none of the participants on that commitment are in Massachusetts. However, Dr. Shafiq Robb, who was then at Rush University System of Health, is now the CIO at Wellforce. And so you may have an asset who's in this early adopter consortium in Massachusetts after all. Do you see that link?
I do, and I pulled it up. Thank you.
So this is an example where if you could first, phase one, do what they're regulated to do anyway over the next 12 months, then phase two, we can tweak it to the changes that are needed to make whatever specific use cases you're interested in happen, if that makes any sense.
It does. It makes a good deal of sense.
My understanding from the EHR vendors is some of them are capable, and some is usually the big players, right? Epic, Cerner, may be capable of shipping bulk fire in production as early as this year in advance of the December 22 deadline. And my buddy Neem
Well,
Gandhi.
we have a large number of those.
Yes, you do. And you've got Neem Gandhi, the new CFO at Partners, who is a juggernaut on this issue. And so for sure, he could be a partner in the cause to bring good energy to life.
Thank you for that. That's very helpful.
Mm-hmm. Anybody else in a position where they can help? Yeah.
Yep. No, I'm finished. I'll let others speak.
Any other members of the audience that would like to put forth a question to Aneesh?
Or a comment. It doesn't have to be
Or
a question.
comment. Yep. So Aneesh, if as you were talking about the rule, and certainly the rule was withdrawn, and then you talked about what about a future rule? How would you guess the future rule would be different from the rule that was proposed and withdrawn?
Oh, yeah, no, the easy answer to that, Charles, is it'll start with including MA. I think obviously MA was not included in the rule, not because there's something unique about MA that didn't need to be in the rule, but because of timing. I think MA rules have to go through a longer process. So an obvious piece would be to extend to include MA, which was not in the initial rule. So that would be like the obvious. And then there may be other items in feedback that they could do to improve. So if there is another rule coming, what are the possibilities? Possibility one is the Biden administration may say, oh, we take the rule as is, we're going to declare it final. It went through a process, there was comments, the Trump administration did finalize it sort of, but it didn't go to the Federal Register. So door number one, move forward. That is possible. That there's no reason why it can't happen. I just don't think it's likely to happen. Door two is to take the same rule and reopen it for comment and then have another round. But again, if you did that, you would still be doing it without MA involved. So that feels like a bit of a weird thing to do, which leads to door three, which is you rewrite the rule, include MA, and maybe make a few other tweaks and you get a new rule. So I think if you were sort of guessing, you would guess that door three is the likely path. Or at least that's how I would do it if I were still in government.
Yeah, sure. And you think then that with door number three and adding MA and allowing a longer comment period, which I think was one of the challenges that we had with the rule, was here today and then implemented. So you think then that we may have door number 3 may be the one to choose?
And I say it's on us, Charles. If Danny says, or Denny, forgive me, if Denny says, hey, look, publicly, we're announcing that we're going to move forward on the provider burden rule with partner A and B, payer provider, and we're going to work together to test these functional requirements. Remember, the whole political fight was the Da Vinci IGs were listed as required, and then the industry said they're not ready for production, right? Basically, I'm oversimplifying. So if Denny announces, hey, we're doing it, and then Weedy says, and by the way, we're going to facilitate half a dozen of these around the country. We're going to do the Massachusetts with Denny. We're going to collaborate with this payer working group. We're going to do this one and this one, just like I did that blog on the link that I put in. We could get momentum around evidence of industry adoption that there are ways to accomplish the functional requirements through technology standards. Then by the time the rule making actually gets to final, we'll have early evidence of what works and what doesn't. And we could all have confidence that we can say, yep, this is possible, it would work.
Well, I mean, it certainly sounds like a reasonable approach. And again, you certainly were there reading the rules, reading the comments, and much of it stemmed to, I guess the concern was we just didn't have enough time. And I think that it was, with another door number 3, there may be some great opportunities for the industry. So is there, yeah, is there any other comments before we have to close? Because I know, Aneesh, you have some other obligations.
Yes. And
we don't want to dominate your time, but certainly want to thank you for your time today. It was as many times as I feel I have seen the presentations, meaning all of the various groups. There is one more question, so let's go back to, do you mind a couple more questions?
Yeah, I've got a call at 5:30, which I'll delay a minute.
Okay.
But just
I
put my email in the chat, Charles. So if Denny in particular, if you want to engage before you make your big announcement about the payer provider, I'd love to just sort of think about how you communicate that so it can be optimized for this to advance this policy agenda, if that's something that you can get the groups to yes on.
Well, we would be pleased to reach out. Thank you for the email. Go ahead, Janice. I don't know.
All right. Hi, thank you. This is actually Janice Perrin, also from the Massachusetts Health Data Consortium or MHDC. And I was wondering if you saw any commensurate changes to HIPAA that would help things along. For instance, one of the issues with the prior authorization rules as they're written is still having to convert over into the X12 formats to be compliant with HIPAA. Do you see any coordination between those things to help this process along?
Can you wait? You said something very exciting. Can you go backwards in time? So, what data you're doing? Are you NEHIN?
Well, NEHIN is actually part of our organization. Yes.
So NEHIN was my favorite. I wrote a case study on Halamka and crew back in the day. I love that program. So repeat the question so I can make sure I get it.
So right now, one of the issues with the prior authorization with the Da Vinci guides and just in general is that HIPAA requires using the X12 formats for data for certain portions of the process. And so the Da Vinci guides are running through hoops to actually do this sort of arbitrary unneeded conversion into X12 instead of doing the entire process through FHIR.
I agree.
And so I was wondering if you were looking for HIPAA, if you thought they would coordinate some of the changes to make that easier.
Janice, good energy and good ideas and cost effectiveness always beat legacy silliness. So let's do it the right way. Let's configure a Smart on FHIR app that a payer sponsors that is allowed to run inside a provider's EHR that can work off of the, ideally on the, look, at the end of the day, the group ID token. So you're Switzerland, right? The Neehan family. So
Yes,
if you
MHDC
shipped,
and Neehan, yes.
if you shipped a bulk fire service where you could work on a group ID token that would allow prior auth apps to be run only on the panel of patients for whom that particular plan is the decision maker, then you can actually, I think you can run this entirely as a bulk fire client. Like, I don't think this requires any kind of weird X12 conversion thing. It just sits natively inside the EHR. And like everything in life, you're either going to do this with CDS hooks, which doesn't yet exist, or at least not regulated, or you're going to do it as a where the physician initiates the request. My take, if I were to sort of simplify it, with the price transparency rule coming, there is no reason why we can't. And what that means is the doctor is going to ask for pricing data for a patient that is about to come in. It's like you get 3 days or 1 day turnaround, whatever's in the surprise billing law. That is going to absolutely drive provider initiated requests. So if a provider initiates the request, the payer is obligated to respond with a prior auth or not. And then if you wanted to, if that is initiated, then you can then trigger the retrieval of the clinical data for that purpose. And so I absolutely believe if you have a payer and a provider doing an announcement that they want to do the prior auth use case, let's team A and team B the work, and team A doesn't require this weird conversion thing, and team B, does what it has to do to meet the rules. And I would promise you a case study on that would absolutely make it through the CMS teams, and there would be plenty of policy interest in cleaning it up. My opinion. I can't speak for the government, but I will certainly, I'm on the team that would be very keen to motivate the process to get that done.
Well, we'd certainly be interested in talking to you further about this.
Yeah. So I'm happy to do it. I love the Neehan family, so I'm all in. And if you're the new parent of the Neehan family, then I love you too.
Awesome.
Aneesh, we really appreciate, on behalf of Weedy, thank you for doing this for us, and we'll make sure on July 13th to send you happy birthday.
Oh, you're funny. All right, thank you. Bye, everyone. Have a great day.
All right, thank you. Bye-bye.
Bye.